So we're very grateful to have Dr. Hurd as a representative of our palliative care service. Not to say the other palliative care docs aren't great too, but we really like to call Dr. Hurd. Dr. Hurd grew up in the Northwest, and after attending medical school at the University of California, San Francisco, returned to the University of Washington for residency in internal medicine. She then stayed to complete her fellowship in palliative care. In addition to attending on the inpatient palliative care consultation service at Harborview, Dr. Hurd is co-chair of the education operations for the new UW Palliative Care Center of Excellence. Her academic interests are in improving how residents communicate with patients facing serious illness. Dr. Hurd.
Thanks so much, Dr. Ram. I see a lot of familiar faces out there. Thank you very much for having me come and speak. Let me just move this up just a little bit. I'm a bit taller than Dr. Ram here. It's really a pleasure. Dr. Ram and I have worked together on collaboratively on many patients. And actually, when I first was going to come and talk to you guys, I was going to really talk about a lot of the patients that we collaborate on who are really sick with a lot of medical illness in addition to their psychiatric illness. And those patients that really, I know I lose sleep over, that keep me up at night. But as I started putting the talk together and thinking about this and realizing that those fortunately, I think, are a small percentage of the people that you guys are really seeing in your practices, and really trying to think about, are there some other tools that you guys could incorporate, some primary palliative care skills that you could incorporate into your practice, maybe more so than just talking about those minority of extreme situations. And if we do have time, I still have slides about those and a couple of patients that I know have really impacted me. Then I'm happy to talk about those situations as well. But I'm really going to be focusing on primary palliative care skills. I don't have any financial disclosures, unfortunately. And so, again, the goal is really, I think, also just to start off with talking about what is palliative care. There's still a lot of misconceptions out there, so we'll spend a little bit of time talking about what it is. And then talk about prognostication and staging in serious psychiatric illness, which are somewhat of a controversial topic, but kind of talking about those, and then using that as a segue to talk about advanced care planning and psychiatric illness. So in talking about palliative care, when palliative care was in its early stages, this is really what the model looked like. Get my pointer here. So patients were diagnosed with a serious long-term illness, and they would get a lot of, their medical therapy, psychiatric treatment, those were things in the beginning, and palliative care was really introduced at the end here, at the time when hospice was introduced. A lot of times I think this was because a lot of patients we were realizing had these needs at the end of their life, but were being treated in the hospital and never really were able to access hospice resources in an interdisciplinary way that we could still try to provide them in the hospital. So I think this is where a lot of it started. But as palliative care has really evolved, we've really moved to kind of a more expansive model. And so this is the World Health Organization definition of palliative care. And palliative care is an interdisciplinary approach with the goal of improving quality of life, both for patients and their families who are facing serious illness. So obviously that's a big, a wide spectrum of people who would qualify for that. With the idea of really preventing or early identification of treatment of suffering. And that suffering can be physical suffering or emotional suffering, spiritual suffering, that we really try to identify those and help assist with that relief of suffering. And I think one of the most important pieces is that it's applicable at any stage of illness. So we get the pleasure of seeing patients who are at any stage of their illness, whether that's curative therapy, working with patients who are getting curative chemotherapy, or whether that is patients who are at the end of, entering that last stage of their life and in the dying process, those patients who are in hospice, we kind of see that whole spectrum. And so this is what the model looks like now. So with somebody being diagnosed in their acute stage of that long-term illness and entering into a chronic stage of that serious illness, and then progressing with them throughout the whole course of their disease, and also being with them in that hospice stage in the dying process. And ideally, if we had all the resources that we needed, we would also continue to care for families of patients who've died in the bereavement process. So that's the ideal way. But what does this really mean? What does palliative care mean? Because I think that's still a lot of a lot of words in that. And I recently went to hear a talk by Ira Byock, who's one of the great minds in palliative care, and he just came out with a new book that's talking about the best care possible. And I think ultimately that's what palliative care is it's the best care possible, providing the best care for patients that reflects their individual goals and values. And, a lot of people may say, well, isn't that what we're all doing? Isn't that what everybody who's taking care of patients should be doing? And it would be great. Wouldn't that be great if that is what we were all doing? And so many of you might know Stu Farber, who's one of my mentors and colleagues over at the U, who's in charge of their palliative care service there and in the Department of Family Medicine. And he was diagnosed with leukemia this fall. And I had dinner with Stu 2 weeks ago, and we were talking about his experience with the medical field. And he had a lot of really interesting things to say. And here's somebody who's spent his career teaching medical students and residents on how to communicate with patients. And he said he has had numerous providers now over these last few months as he's been in and out of the hospital who have cared for him. And he said out of all those people, everyone is incredibly well-intentioned, and they're caring, and they are smart, and they know their facts about, how to take care of patients from a medical standpoint, but only 1 or 2 of them have actually sat down and asked Stu or his wife, what is your life like outside of the hospital? What is truly important to you? How has this experience been for you being sick? And he's been really surprised by that. And I think it would be great if we were all doing this, but the reality is that that's not happening. And I think it's taken palliative care to kind of remind us how to take care of patients kind of in that holistic way. And there have been, a lot of tremendous, studies done on the impact of palliative care, showing, impact from whether that's physical well-being to emotional well-being, very high patient and family satisfaction, and also increases the likelihood of that patients die outside the hospital, which when most Americans have been surveyed, that is a priority for most Americans, not all. But I think probably the biggest landmark study that is referred to as the one that was done in 2010 by Temmel and her colleagues at Harvard. And this was one of the first real randomized control trial looking at palliative care. This was in outpatients who had stage 4 non-small cell lung cancer. And there were almost 150 patients, I think there were 151 patients that they randomized to receive either standard care, which included chemotherapy or radiation, or standard care plus palliative care. And this was primarily outpatient palliative care. So this was them seeing a palliative care specialist, working on symptom management, advanced care planning, those sort of things. And so what they found, which I don't think too many people were surprised about, was that patients who received palliative care reported higher quality of life. And they also reported lower depression scores in a number of different scoring systems. But what surprised people the most about this trial was that when they actually looked at survival, they actually found that on the median survival of patients who received palliative care was on average 2 to 3 months longer than those who received standard care. And most surprising this was that those were actually the people who received palliative care actually had less aggressive treatment at the end of their life. And so this has really bolstered the prominence of palliative care and really tried to incorporate that more into how we care for patients. But what does this mean for psychiatry? A lot of this work has been done outside of the field of psychiatry. This was a quote by Dr. Griffith, who writes in the psychiatry rounds. He's done a number of case studies in the Journal of Psychiatry. And this was one of his quotes that he said. He said, "The psychiatrists and other team members often care for patients over many years and gradually learn about patients' wishes and preferences, strengths and limitations, and areas of support and lack thereof. The psychiatrist is in a unique position to provide empathy and many of the necessary elements for palliative care during the final phases of patients' lives." And, psychiatry, much more so than, really any other field of medicine, is really about, having that conversation with patients, counseling them, being there at over many years often in a patient's illness, and really developing this therapeutic relationship. A lot of that centered around that counseling component. And so you guys are very uniquely positioned to be able to think about these things when caring for patients. And I'm hoping that we can just highlight some of the components that you could incorporate more into your practice. And this discussion about primary versus specialty palliative care has become really prominent, really even in the last 1 or 2 years, as we've, this need for palliative care has come into play, and there's just not enough palliative care specialists to be able to supply all this need. I mean, most of the palliative care predominantly is still in inpatient settings and not really in outpatient settings. And so this idea of primary palliative care has become really important. And, you know, how do we do that and what components that are so we can try to have these sort of things reach all patients who would be eligible for them. And, you know, there's a lot of parts of this, but I would say a lot of it is kind of that initial management, basic symptom management, especially in terms of pain, and other, you know, initial assessments of patients' values around their cultural and spiritual needs, other needs around their medical care, and identifying ethical concerns, conflict when there's conflicts among providers and between patients and their families, or patients and providers. And then some basic knowledge of hospice and caring for patients when they're dying. And specialty palliative care is really taking all of these things and then kind of pick your most complex scenario of that, and that's where we can come in and help. But I think a big part of this, and definitely something I'm in internal medicine, so I'm a little bit biased from that perspective, but a lot of what we work with our residents around is around this idea of prognostication and around advanced care planning. And prognostication in psychiatric illness is difficult, and we'll talk a little bit about that, but and kind of how this can be helpful and how maybe it can't be as helpful. So in talking about prognostication, so this is a quote from Emil Kraepelin, who really was one of the early people who was describing schizophrenia or dementia praecox at that time. And so this is from the turn of the last century. And he said, the prognosis, however, is really by no means simple. Whether dementia praecox is susceptible of a complete and permanent recovery is still very doubtful, if not impossible. But improvements are not at all unusual. It is a more serious matter that in most of these cases, the improvement is only temporary, and that such patients are in great danger of relapsing sooner or later without any particular cause, and then generally suffer more serious injury from their illness. Now, fortunately, we've come a long way from this, and even actually, Dr. Kraepelin even admitted kind of when he was still alive that there was a lot of potential for recovery, and I think we have really, and you all would be, you know, much more familiar with that, with this, more of a recovery model of care and how we care for patients now, and really that there is a lot of potential there for patients to recover and really live very satisfying lives despite having long-term mental illness. But I think even with that, we all know that there are those patients that we take care of who, despite all of those measures, still are really struggling with their mental illness. And how do we also kind of recognize that and be able to care for them as well? And I think, you know, when we talk about prognostication in patients who have serious mental illness, we can't ignore the medical component of that. And I was really struck. I think I knew that that was there, but when I really was looking at this literature, it's really striking how significant of a role that plays for many reasons. But I mean, on average, patients who have serious mental illness die 25 years earlier, which was just, I mean, I hadn't really seen that figure. Oh, I'm hearing no.
It's not true when you attribute poverty into it.
Yeah, right. So yes, and this is taking into consideration all of those socioeconomic, you know, all the factors that play a role.
So when you do poverty, it only goes to 12 years.
To 12 years. Okay, so I mean, I think that's still really striking, though, even thinking about 12 years. I mean, that's startling to me to think about that, because that's even when you think about, if you take out poverty, which is really hard to do with the majority of patients I'm hearing.
You compare them to other poor people.
Oh, to other poor people. Okay. But how big those? But I'm saying that these are people who often have both of those things going for. Is what I was saying. Is that, I mean, that's a significant factor for the patients who, especially those of us who are caring for people at Harborview. It's really amazing. And then a lot of this is attributed to their comorbid medical illness, and a lot of that is cardiovascular. You know, with a lot of our medications, how big of a role that really plays for these patients. And so they're getting these at a younger age, and they're always also having poor quality of care. And it's not just, I think a lot of us think of underuse and that accessibility component as being a big part of that, you know, not having access to those resources for not just the way the healthcare system is set up, but also based on their own factors in their life. but also overuse. So giving patients things that are not necessarily indicated or possibly medically futile. And the other part of that is misuse. So not only when they get the care that they need, they have higher rates of medical complications and medical errors, which is worrisome. And there was an interesting study that looked at patients in Canada that has a national health system, and looking at patients with schizophrenia and their access to medical care, and found that a large proportion of these patients die in nursing homes compared to the general population, and they have significant lower access to palliative care. So in this study, the general population, about 18%, which is still a pretty small number, had access to palliative care, whereas only 7% of patients with serious schizophrenia had access to palliative care. And they looked at some of these patients, especially who had metastatic cancer, and how many of those were actually prescribed narcotics during that illness compared to the general population. And that was 47% in the general population of people who have metastatic cancer, compared to 30% in this population of people with schizophrenia. And so why do we prognosticate? A lot of this literature is around medical illness. And prognostication, I'll talk a little bit about some studies in psychiatric illness, but most patients in the general population want to know. So this was a study of cancer patients. 87% of patients, whether good or bad news, wanted that information. And 83% of older adults and caregivers with serious illness who believed they had less than a year left to live wanted to know how much time they had. Now those numbers go down in patients who don't think that they have as much of a limited life expectancy, and so that's important to know that not everybody wants to talk about these things and is ready to talk about these things. But when we do tend to prognosticate, we tend to be pretty bad at it. So this was a study looking at patients going into hospice, and only 20% of our predictions were accurate. And when we did predict, we were 5 times more likely to be optimistic, on an order of 5 in terms of being optimistic when we did make those prognoses. So obviously that really, I think it all comes from a good place of being overly optimistic, but when we are overly optimistic, we really limit the amount of time that people have to be able to complete life tasks, prioritize the things that are important to them. And also this lowers the rate of referral to things like palliative care and hospice when they truly are indicated. But, the illness trajectory in psychiatric illness is much more difficult. When we look at a lot of these other medical illnesses, these things are much more predictable. Obviously, there's a lot of variability in these. But when you look at cancer, people tend to lose most of their, tend to lose most of their function in the last 2 to 3 months of life when they have cancer. So they go along, they're generally doing pretty well, and then when they start to decline, there's often a very steep decline at the end. Those with organ failure, so one of the classic examples is heart failure, where patients maybe have a slower decline over many years, but during that decline, they have these significant episodes of setbacks, hospitalizations, exacerbations, but often are able to get pretty close to where they were before, but then that slowly declines over years until usually there's a sudden event that happens, a cardiac arrest or something like that, a respiratory failure arrest. And then there's dementia, which tends to have a little bit more of a predictable course, but over a period of many, many years with a slow trajectory. But when you look at psychiatric illness, that's just all over the place. And you have patients who, they come to you and they might just seem like they're doing terrible, and they get treatment and they get more support and they get more therapy, and they have this incredible resilience to them. And they could have very times when things are really terrible, and they get back not only to where they were before, but sometimes even better than where they were before. And then you do have patients, though, who do have that other course where they have, continued difficulty, multiple rehospitalizations. Maybe they spend a significant time of their life, especially in later mental illness, in an institution. But that is all over the place, and it's really hard to predict with any one patient what that's going to look like. And when I was looking at this, I tried to look at just some of the trials, like was there really anything out there to kind of help us with that sort of information? And there's been some of these big trials, the STAR-D, and I think a lot of you would be much more familiar with this sort of literature than I am. But trying to look at people's response to treatment. This was the STAR-D trial that had over 4,000 patients that were enrolled, and was kind of started on level 1. Everyone started on citalopram, and there were varying protocols of what the provider could do from there. And when you looked at this, the average accumulative remission was 67%. And so that means that there was still over 30% of patients who didn't have a remission, but this is complete remission. And what it really doesn't help us is about, well, what about the patients who have a partial response, and what does that mean in terms of their day-to-day life, that they can still have a significant quality of life even if they don't have complete remission. And the CATIE trial, which was in schizophrenia, tried to look at response to treatment. They were randomized to one of 5 agents. And look, there was an incredible high rate of dropout with any of these medications. Actually, it was pretty startling. But they further looked at this data in 2012 to try to look to see were there particular patients that responded in one way or another. And so this is showing just here at the bottom, these patients were particularly good responders. So this is the change in the positive and negative scoring system. So negative being a better response with a decrease in the scoring system. And so these patients at the bottom, which is about 20% of patients, were the really high responders who just seemed to have a really robust response. And there was higher ability to adhere to regimen and things like that in that group. But even people who dropped off but were still in this, who stopped taking the medications, were still in this group. And then you have patients who are in these other 2 groups, so they call them the low deteriorators, which was really the majority of patients were kind of this slow decline in their, or so I guess you say continuance of their schizophrenic symptoms. And then a group that really had significant deterioration over time was another 11 or 12% of patients. But again, this really doesn't speak to what does this mean in terms of the actual patient sitting in front of you. Other people have tried to talk, to say, okay, what is treatment-resistant schizophrenia and what are the criteria for that? But I think these have the same difficulties there. And kind of where do people fall on this spectrum? So we talked about those who are really responsive to treatment, those who have a chronic mental illness where they have very long periods of remission, those who have more of that severe persistence. So this is really defined as somebody who has long-term mental illness, but it's impacting their day-to-day activities of daily living. And then those apparent treatment resistant. These are the folks who, if they seem like they're not responding to any sort of treatment, but really that's because all these other psychosocial factors that are there that aren't enabling them to engage in the treatment that's available to them. And then in the end, you have those patients who are terminal. And I don't even know if I would be able to say that this is a true definition in psychiatry. I think most of the patients that I came across in the literature where people were talking about this, there's a very few examples. I think probably the most common example that's discussed is eating disorders, where it has, the highest mortality rate directly from the psychiatric illness. And a few examples that I came across in patients who had really strong fixed delusions, especially around things like their nutrition that directly then impacted their health. But I'd say the vast majority of time when we're thinking about patients with psychiatric illness who are terminal, we're really thinking about that in the context of what other medical comorbidity is that they're facing. And so I think, people have tried to also use the staging model of this for psychiatric illness. And, why do we use staging? So in kind of the medical communities, we use staging to have a common language for people to communicate, especially in terms of clinical trials. And we use it to really identify treatment options. So people who have stage 1, cancer might be eligible for this sort of treatment, whereas people who are at stage 4 might say, we know that the people don't respond to this sort of treatment. Let's immediately get you into clinical trials or whatever that means. And then we also can use it to estimate patients' prognosis. And Dr. McGorry and Dr. Burke in Australia have proposed some staging models for mental illness. This is the one for bipolar. Dr. McGorry does a lot of work mainly around youth and mental illness, and really a lot of work around prevention and early intervention strategies, with, again, the idea of really supporting that recovery model of care. And I think this is really where the staging is, the purpose of staging in psychiatric illness is to really identify what resources do we need to get in place at these early stages. So as somebody progresses through these, early on, somebody might be asymptomatic but high risk. Someone may have mild or non-specific symptoms, and then prodromal features, and then their first episode. And as you can see, they step up in terms of the recommendation of what those patients would need, with the hope of trying to intervene early on before you have this cascade of events that happens, and potentially, biological changes that happen in patients that might make them more resistant to treatment later on. But I think one of the nice things that I like about this staging model is really when it talks about stage 4, is it talks about social participation despite disability. And I mean, the purpose of these stages, I think, is not, and even in other disease models, if you think about heart failure, is not that you progress through these in a linear fashion, and once you go to one stage, you're never able to get back to another stage. But really as a way, again, to identify treatment options for those patients with the idea that you can hopefully actually have them reverse back through these stages. But I think in those patients where you still have really tried everything kind of in your arsenal, to try to think with patients is how do we then, a lot of the literature that I came across talked about this dichotomy that we can get in with patients with mental illness around kind of success and failure. And I think you see that a lot too in oncology, kind of the battle that we're fighting, as the classic example. And that can, in some patients, have a very significant sense of failure. Then when that treatment doesn't work out, that sense of failure, my gosh, I'm never going to be able to get on top of that. And so trying to help them reframe that and say, okay, we're kind of in this sort of situation. How do we adapt to that? What are the things that, let's talk about some goals you think that we can accomplish together, and how can we make those happen instead of having this, this illness go away completely. And I think this fits in nicely with, again, that idea of the recovery model. And when I was looking through these, I was like, oh, this sounds like palliative care. I mean, so recovery is holistic. It's about peers and allies. It's about your relationships. It's about your community supports. So all of those things, I think these dovetail really nicely with those same concepts of palliative care and really caring about the whole person. And again, I think you can't look at prognostication in mental illness without thinking about prognostication in medical illness. And so I think even as psychiatrists, I think having a sense when your patients have serious medical illness is taking that into consideration, saying, okay, well, what does this mean just in terms of their life expectancy from their other medical illness? I think it's always shocking to me to read when patients start dialysis that the 5-year mortality is 60%. Which is really shocking. And I think I know I have several patients who I know have been on dialysis for many years. One patient who I was going to talk about if we did have time, who's been on for over 20 years, who has schizophrenia, who I think a lot of you know well. And so we have patients who do very well on it, but we also have a lot of patients who don't do very well on it, and that those are really times to say, okay, is this the time for me to think about advanced care planning? And so when I think about prognostication, I think less about this is, telling a patient this is how much time you have left, and, this is what I expect to happen. And it's less about that. And it's more actually for me as a provider to say, gosh, what is kind of a reminder of what is happening with this patient? We can go down the medical train and you can kind of continue on with this treatment and this treatment and this treatment without really taking a step back and saying, okay, is there a time here where we need to step back and make sure we really are understanding from the patient's perspective what's important to them? And so I see it more of as a stepping stone and as kind of a call to action to say, okay, let's maybe have some bigger conversations if the patient wants to do that. And as you guys, as the provider, to initiate that process. So advanced care planning in mental illness. And so what does that look like? So I came across, this was a woman who is from Australia, and she considers herself a consumer advocate for mental illness. She has bipolar herself, and she's also a comic. And she does these cartoons herself. And so this is one of her cartoons, and it's talking about advanced directives. You can see the psychiatric unit there in the distance. And these are people's demands. So one person says, I'm allergic to cauliflower. And the other one says, no ECT for me, please. It doesn't work. And so I like that image. And so what is advanced care planning? Oops, sorry. So it really has 3 components. So one is identifying a healthcare proxy. 2 is identifying treatment preferences for medical care. And then the last, and I think the most important piece, is really communication of those treatment preferences. And then the advanced directives are then the legal component of that. So the document that actually communicates those choices, whether it's a durable power of attorney or a living will. And so Dr. Foti at the University of Massachusetts has looked at advanced care planning in people with serious mental illness. And they worked with over 140 patients, and this was in Massachusetts. And I would say the biggest probably downside of this study was they solicited for patients in by flyers and kind of posting. So I think there's some bias there in terms of who is actually volunteering for this. But where those postings were they were in residential facilities, group homes, things like that. And so they looked at a potential population of 450 patients in Massachusetts who met the criteria of severe and persistent mental illness, who were living in those sort of kind of monitored settings, which was about 450 patients, and 150 of those volunteered to then be in the study. But I think that it still has a lot of really important information that came out of it. And I think it's interesting to compare this to kind of some of the general population. And so about a third of them, or a little over a quarter, had existing preferences about what they would want should they become seriously ill. But only 5% of these patients had actually talked to their provider about what those preferences were. And this is much lower than the general population. So a quarter of the general population have actually talked to their providers. And only 2% had actually documented any of these preferences, even though in the general population that's 29%, which again is still really quite low. But is significantly lower in this vulnerable population, but yet 3/4 of them thought that somebody should be designated to make healthcare decisions when somebody is seriously ill, and in fact 62% of them had somebody who they would identify in their life as who they would want to be that person. And I think what was one of the most, and I think this makes sense, but I think it's still striking to see the numbers, is that 43% of them would choose a family member, but that means the other vast majority would not choose their family member, whereas in the general population, that's 87% would choose a family member. And I think this speaks to a lot of the social isolation and estrangement from family members that can happen in mental illness. And also some of them just, may think that other people would make better decisions, and I'll give an example later on. But I think, again, just really striking that if we don't ask, because who is the default decision maker when these people are seriously ill? It's family. And so if that's not who they want them to be, then we really need to know that. And only a small percentage, 18%, had actually chosen somebody to be their healthcare proxy. One of the other things I did like about that study is that people who did have guardians were actually able to enroll in that study, and they got consent from both the guardian and the patient. And they also looked at how comfortable were these patients talking. That's a big concern, not just in mental illness, but in all the population. Do people want to be talking about this? But they found that the majority of them felt comfortable talking about end-of-life issues, and that the majority of them noted either no to minimal stress or some to moderate stress from the interview, and only a small percentage of them said they had a great amount of stress. And they had pretty good understanding. They felt like they had pretty good understanding in terms of the questions that were asked. And then they looked at actually treatment preferences. So they gave patients two scenarios. One was a scenario of a patient with metastatic cancer and what would they want around pain medicines. And the other one was a situation in which a patient had irreversible coma. And what they did was they first had the patients actually say what they think the patient in the scenario should have or would want, what they would do for that patient, this imaginary patient, and then they were asked what they would do for themselves, and there was good congruence there, that for generally what they would choose for somebody else is what they would choose for themselves. And so in the situation of irreversible coma, a third of them would want life support terminated immediately. And that's quite different than the general population. So 48% of people in that scenario would want it terminated immediately. And another, a large portion of them, so 43%, so almost half, would want to wait a defined period of, then they define 7 to 30 days in this to kind of see what happened. A lot of them noted, with the hope of a miracle would happen or something like that. And this is much higher than the general population, so which is around 30%. And then there's a good portion of them, so 28% would want that care continued indefinitely. And they noted the reasons as being two main themes came up. One is that, again, hoping for some sort of miracle that would happen. And then the other one was just that any life is valuable. And this is much higher than the general population, which is more around 14% of patients would want continued indefinitely. And these numbers that patients with serious mental illness gave are similar to the numbers in other groups that have known healthcare disparities. So especially in other racial ethnic groups such as African Americans and Latinos, that they would tend to want some of that more aggressive care. There's a portion of them, a larger portion of them than the general population, that would want that sort of care continued indefinitely. And I think it highlights that if we don't ask, then we don't know. And the person who wants it continued indefinitely is very different than the person who wants it stopped immediately. And again, if we don't ask, we don't know. And that care would be very different for those patients. And we want to be completely supportive of whatever that care looks like for that person. And so a lot of people have recommended psychiatric advanced directives. Or do any of you how many people have heard about psychiatric advanced directives? So quite a few people. How many people have done them with any patients? Okay, I see no hands. Okay. So there was a statement that came out with the American Psychiatric Association just in 2009, so not that long ago, really insignificant support of psychiatric advanced directives. And there have been some nice studies. The main one was from Swanson in 2006, which is now quite a bit ago. But looking at, they actually randomized patients to receive them and then looked at some of the outcomes. And what they found is that patients had increased feelings of therapeutic alliances with their providers. They felt a greater amount of treatment satisfaction. They felt like they had greater perceived autonomy. And a lot of these were, I want to say these were patients who were involuntarily held. And that, or maybe had been involuntarily held at a point. And they actually looked at, they had increased treatment decisional capacity, and they felt greater satisfaction with the type of health care that they were getting and the type of mental health care they were getting. And from this study, actually, this was done out of Duke, and they got a MacArthur Genius Grant to actually start, this is the National Resource Center on Psychiatric Advanced Directives, and I was really hoping the computer can't see PDF forms, because I was really hoping to actually show you, because it's neat, you can go here, and you can click on, here it is. You can search by state. You can click and search by state, and so I clicked and pulled up Washington State, and it has our state specific. So if you leave the state and you practice somewhere else as residents here, you can go to this and still access this. And so what does the advanced directive have in it? It has a lot of things that are different than regular advanced directives. It has a lot of things around what types of medications patients want, what kind of bad reactions they've had in the past. It does talk about things like ECT. It talks about if they're incapacitated, how do they want to be treated, in terms of like de-escalation strategies and things like that. It's really quite extensive in there, and I think it's an interesting document, even if it's just one that poses a potential for discussion. And I think this goes back to kind of what are the pros and cons of advanced directives. They're not kind of this end-all be-all. I think one of the big pros of them is that it really gets people thinking, it gets people talking, both among the patient and their family or their healthcare proxy, and also the patient with their provider, and just get something down on paper. And many studies, at least in the medical literature, show that surrogates who have, it's one of the biggest points of stress when making decisions as a surrogate, is not knowing what the patient would want. And that has actually been shown to have significant PTSD, rates of depression in surrogate decision makers over the long term. And knowing what a patient wants has been shown to actually decrease those rates. So I think a really important piece of that is just that component. But the truth of the matter is advanced directives are still about a theoretical thing in the future. And it's patients having to think about something that, although a lot of times in these psychiatric ones, these are again about involuntary commitment, about medications and things that they've already experienced, but it's still talking about things in the future. And obviously things can change. So the example of one of the patients that I took care of that we won't have a ton of time to talk about, but I'll briefly talk about her, was when I was on the medicine service, and she was a woman who had very severe bipolar. She'd had bipolar since her teens and had had several involuntary commitments over the course of her life. She was in her 50s when I saw her. And she had had progressive renal failure, thought initially to lithium, and then probably to kind of neglect of some of her medical issues over time. And anytime she'd been involuntarily committed, And on medication. She would take those medications for maybe several months, even I think sometime in the past she would take them for a few years, according to her family. But then she would pretty much go back to not taking any of her medications, and she would do fine for many years, actually, in time periods between that. And she was brought in because she was having epistaxis, and she had, her blood pressure was in the 240s. She had platelets of, in the teens. Her creatinine was 10, I think, when I saw her. And she was not taking any of her thyroid medication. Her TSH was through the roof. All of these things were happening, and she had been adamant consistently then and over a lifetime, well, at least as long as she had renal insufficiency, that she would never want dialysis. And so, we did treat her for a time period with a psychiatrist, and under a compel, she was considered gravely disabled, with the hope that she would gain some more insight about her medical issues. And although it improved a little bit to the point, especially that she would take her thyroid medicine, she really wasn't budging on anything else. And she felt like it was a huge impact on her quality of life to stay and be committed. And she had a lot of things that she loved doing. When she was a Christian singer, she would sing. That was her job. She would go and sing at nursing homes and things like that. And so after an ethics consult and a lot of distress among all of us, decided ultimately, with the help of her family, that we would have her go home and go on hospice. And I followed her as her palliative care provider. And not too long, so the great part was her whole sisters got together, they took a cruise to the Caribbean. That was one of the things she really wanted to do. And it really changed the dynamic of her relationship with her sisters, where they kind of said, we're just going to support whatever it is that you want to do. If you want to do this, great. If you don't, we're not. And where they'd been in a very adversarial relationship for many years. And there was a lot of healing that took place. And a couple months later, she ended up having worsening shortness of breath and pulmonary edema, and was readmitted at Evergreen, and I went and saw her there. And she tried dialysis, and she started it. And she did it for a few days, and it went okay. And then so she was discharged with a fall plan, hated it, didn't follow up, was off dialysis. And then a few months later was on hospice, off hospice, on dialysis, off dialysis. And in the end, though, she has now been on dialysis. It's been 2 or 3 years now. And she goes to dialysis 3 times a week and continues singing. And so I think that ability to be able to change your mind and adapt to kind of where the patient is at, I think, is so important. And again, going back to kind of what's really important to the patient in that moment. And I think advanced directives can't really always predict that very well. And so we're running a little short on time, but I think, how do you actually do this? This is just, I think, some of the words that we use in palliative care when we're talking with patients. And I think if you're just trying to start the conversation with patients, these are the sort of things that you can bring up is, how is your illness impacting you and your family? What's important to you? Who's important to you? What are you hoping for? What are you worried about? And where do you get your strength from? And so to take my own advice in this, I figured I should actually, practice what I preach. And got permission to share her story with all of you. My cousin has struggled with bipolar for many, many years, and substance abuse in her early kind of in teens and 20s, and has now been sober for over 20 years. She's in her 50s now, and she was a practicing real estate agent in San Francisco for many years, very successful. I lived with her off and on when I was homeless, especially living in San Francisco for different time periods. And she and I have been very close, and over the last 3 or 4 years, her bipolar has gotten significantly worse, and she's had a very hard time keeping her job. She hadn't sold a house in a few years. Her finances were very minimal. And in the meantime, her mom, who's my aunt, was diagnosed with a sarcoma and died. And you can imagine that was a very difficult point for her. And my dad is actually her payee, so he pays all her bills and her rent and that sort of thing, especially her health care insurance, which was a big thing. And I'm her emergency contact. So a couple months ago, she was involuntarily committed down. She lives in San Francisco still, and at Kaiser, and they called me, and so we had a conversation, and I realized that when I was preparing for this, that I hadn't done any of this for her at all, and so I was like, okay, so I called her, and I was nervous. I'm nervous. I'm like, oh, okay, we should really talk about these sort of things, And I was just kind of nervous how she was going to react. And it was just, we talked for about an hour and a half, and it was just lovely. And I just wanted to share some of the things that she shared with me. And so I said, well, tell me about your perspective on how things have been over the last few years. And she said, the last few years have been some of the hardest of my life. I often know what the best thing is for me, but I don't have the ability to do it. And I asked her about what's important, and she said, I don't anticipate a long and spacious life. I prefer a more concentrated and useful experience, but it's the little things that keep me going. A great story, a piece of art, the little beauty. And I think, there's a part of me sometimes especially when I talk with my dad, I think, oh my gosh, how she seems so miserable sometimes when you talk to her, but when you really ask her still what's important, all these other things, really the small things are still keeping her going, and she's always been somebody, she reads a ton, she reads the New York Times and everything every day, very, very bright. And just kind of devours all of that. And those are the things that still keep her going. And we talked about who's important. And so she mentioned me. She said Paul, that's my dad, and her sister. So she has two sisters who also have their own challenges. And we talked about, she said, though they also drive me crazy. And she said she misses her mom. She said she'd lost a lot of friends the last few years and that this had contributed to a feeling of isolation. And then we talked about who she would want to make medical decisions for her. And this was really interesting. She has me as her emergency contact. My dad is her payee. But yet you could see her struggling when she knew that her sisters, especially one of them, would be very mad at her if they were not the decision maker. And so we were talking about brainstorming about ways to deal with that. And could we come up with, having a surrogate decision maker where the four of us were all on there and kind of made decisions together. And she, I couldn't believe how excited she was about this. And actually that there was a lot of relief for her to be thinking about, to be thinking through this and how grateful she was. And then I said, well, have you talked to your sisters about any of this? And she said no, but they would be delighted. And it was interesting. It was really not the response that I had expected. And so other things, we talked about what she's hoping for. And I think if you had asked her 10 or 15 years ago what she was hoping for, especially from her medical treatment, I think it would have been very, very different. But right now, she talked about to have choice. She said, it's like they label you as this, and now you have to take this. But then she talked a lot about symptoms, not being so nauseous, getting better sleep, having the energy to get up in the morning, and then to tell stories. That was something that was very important to her. We talked about how she would feel if she was in a car accident, had a lot of disability, and needed to live, with higher levels of care, what that would be like. Although she struggled with that too. One of her biggest fears is losing that independence and not living in her own apartment, which has been very difficult because it's an expensive apartment to maintain at this point, which we're running out of finances for that. But and the other fear was a large part about being involuntarily held again. And she's described that situation as really irritating. It took respect out of the equation, and I was in such a subordinate role. I was very offended by that, which is understandable. And talking about strength, she actually brought up, she's been in an outpatient group through Kaiser. She said that has been really helpful. And it was interesting because when she got out of the involuntary, she did not want to go to that at all, but she has been going. Not it's drop-in and not all the time, but it's neat to see her kind of engaging in those therapies. And I think, again, going back to that, having kind of realistic expectations about what she can and cannot do and reframing that a little bit, I think has been really helpful. So there are some other resources if you're really, there's the Conversation Project, if any of you have heard of that, which is really, I think, more talking about end-of-life preferences. But in here, if you do have a patient who doesn't really want to talk about those things, I think if there's a script and all of that sort of thing, I think it can be a good resource for people who don't know what to say. But I think at the end of the day, it's really about identifying those people in your panels, the patients who you care for, about who would be a good candidate to talk about these things. So I think about, the people who are healthy, kind of doing pretty well, maybe have some comorbidities. Those are the patients who I just think about, gosh, can I just get them to think about who they'd want to make decisions on their behalf. And this is really important for our patients at Harborview, especially our homeless patients who are estranged from family, who don't want their family to make decisions. I would say that a large proportion of the patients I see do not want their family to make decisions for them. And so I think if you can even get that done, great. And then those who have, go ahead.
Yeah, so practically, if you get them to identify BPOA, do they have to sign the legal paperwork? Like, do you get your social worker in the clinic to come in and help?
That's a really great question. So Lauren just asked if you are if you do this paperwork with a patient. So in the state of Washington, DPOA of healthcare paperwork does not need to be signed, witnessed. It doesn't have to be notarized. The patient can fill it out anywhere and have it in their own house and have never shown it to anyone, and it's still considered valid. And a lot of other states have verbal consent of this, which I feel like is not totally the case here, but you don't have to have the social worker do it. That being said, I oftentimes have our social workers do it, mainly because it gets documented in a different way in the chart, and that's often the place that people look, and then the social work notes and that sort of thing is to look for those sort of documents. Although, I think with ORCA changing, I think we're getting better about accessing these kind of documents. And I think revisiting that too. That person can change. That person who they wanted to make decisions has died or has their own health problems or whatever it is. It's not something that you can then just make and then move on. And the same thing with advanced care planning. I think it's less about whatever specific document you fill out, and I think it's more about just having the conversation with them and asking some of these things, and then having that conversation with the surrogate decision maker, and so that everybody's hearing the same information. And for those patients who are really seriously ill, who have a lot of instability, those are patients who I really think about doing a PULSE form with, which is a physician's order that's actionable, where you can actually follow those orders if they're incapacitated around things like CPR, intubation, other medical care. And it's a little bit tricky when that comes into psychiatric care and kind of the legal, limitations around that. But I think it's still a very helpful document. And so this was what I was planning on talking about. Again, are those patients who are really incapacitated, where there's all those ethical competing priorities. And this would be a whole talk in and of itself. But I think, at the end of the day, what I go back to is really how our ethics group here makes decisions is really with the 4-box method, the Johnson's method, which is really a palliative care approach, which is thinking about, okay, what is the medical, this is that prognostication piece, what are the risk benefits of that treatment, what's the likelihood of success of that treatment, the patient preferences, what do they want, what have they wanted over time, is this consistent with who they are as a person, is it authentic to who they are, or is this really different from what they've stated they wanted in the past? And then quality of life concerns, again, especially when those burdens of treatment, especially as we start to think about even just our antipsychotics and things like that, as we try more and more agents, a lot of times those side effects become a much more prominent part of that. And then contextual features are all the other things about the healthcare system, about the providers, about bias, about family, all those other things are all really important. And this is that constant balancing act, and this is a part from the modern Hippocratic Oath where it says, I will apply for the benefit of the sick all measures that are required, avoiding those twin traps of overtreatment and therapeutic nihilism. And I think this is the balance that we constantly are trying to walk with our patients in this. And I'm just going to end. This is Susan Block. I don't know if any of you know her. She's a psychiatrist at Harvard, and she is the director of their palliative care program at the Dana-Farber Cancer Institute, and is really a huge person in palliative care. Has published many things on this, and this is what she says about psychiatry. She says, psychiatry has changed a lot in recent years. There are a lot of frustrated humanists who are getting pushed into just doing psychopharmacology, but who really care about the patient's existential issues. Those are the psychiatrists I'd look for. They'll find they can learn new things and grow in every way from their involvement in palliative care. In summary, talk to your patients. I think if you at least even bring it up, talk about surrogate decision makers, talk about what they're hoping for, what they're worried about, you're doing much more than really any clinician is doing already. And I want to give special thanks to Carol Alvarez, who I know couldn't be here today, but and I know most of you work with her, who's just been amazing. And I have learned a great deal from her and continue to learn from her, as this is a field that I am learning a lot about, that I don't have a psychiatry background other than medical school. And so I've learned a great deal from her and continue to do so. And that's it. Are there questions?
I just want to say, from a practical perspective, going through the whole spheres, quality of life concerns and perspective has actually been a lot less scary to do once you actually just start doing that with chronically mentally ill patients, and they really appreciate it. And I think the other thing that you mentioned was that 5 wishes form, which is also, I think, really comprehensive for these patients, and for us, because it already tells us, what are the 5 different realms of end of life care that these kinds of patients are really going to be.
Yeah, I agree. And I think that what are you hoping for, what are you worried about is a very non-threatening way to talk about these things. And I think that's really what we work with residents and doing and talking with all patients is that's a kind of that's your gateway into it. And then that opens the door and you'll find that a lot of times the conversation will just naturally drift to talking about other serious things. And, I think the thing is that you just are starting this conversation. You don't have to get everything, we don't talk about code status when we're first talking with patients, and that's not a huge priority of mine. I really want to learn about them and what's important to them. And the 5 wishes, I think, is trying to do that. I think it's trying to get at, if any of you know that other document, it's an advanced care directive document that is legal in the state of Washington that patients can fill out. And the nice thing about the 5 wishes, I think, is that it's not so black and white. It gives patients a little bit like, well, if I do have, a terminal illness, I'd like a trial of, A, B, or C. And then if it's not working, I'd like it stopped or those sort of things. So I think it leaves a little bit room for flexibility. Okay. Oh, yes. Thank you.